Hi there, I'm the neuromuscular mechanic, and today I'm going to be talking about ultrasound guided proximal median nerve blocks. So, what are the indication for these injections? So, as a physiatrist, I use them for diagnostic nerve blocks for spasticity. So, the patient that presents with a clenched fist, is it spasticity or is it contracture? Well, what I can do is I can block the median nerve that is supplying muscles contributing to that clenched fist, such as the flexor digitorum superficialis or the FDS, the flexor pollicis longus or the FPL, the flexor digitorum profundus, and the lumbricals to digits 2 and 3. Again, it's not the only nerve that contributes to the clenched fist, so I'm often blocking the median with the ulnar nerve, but it's important to know. And then if you're an anesthesiologist or a surgeon, you may use this for local anesthesia for a surgical procedure. So like my prior videos, I like to go through a checklist. So before we look at ultrasound videos, what's the ideal patient position for this proximal median nerve block? What transducer should I use? Where do I put the probe to start with surface localization? What structures do I identify on pre-scan? And how do I get after my target? So with patient positioning, you'll have them supine, arm to the side, elbow extended, hands supinated. You can imagine that if your patient has spasticity, then the elbow might not be extended, the hand might not be supinated, so it can be challenging. Because the nerve is relatively superficial, we're going to use a high frequency linear ultrasound probe to get the best resolution, and that usually suffices. Then, with surface localization, I'm going to start at the antecubital fossa and short axis. It's a very great area to identify the brachial artery, and regardless of the muscle echo texture, you'll be able to appreciate that artery, as well as the trochlea, which is part of the humerus. And so, if you were to follow that brachial artery just a little bit distally, the median nerve will be in the fascial plane with the brachial artery as it courses through the two heads of the pronator teres. And so that's what we can do for surface localization. Now, when we're doing this, we want to, as part of our pre-scan, obviously identify the brachial artery because that'll help identify the median nerve. Again, the brachial artery, regardless of muscle hyperechogenicity, will be able to identify the trochlea of the humerus. You need in your mind to understand where the median versus the ulnar nerve are or is, so we're going to talk about that. And then the pronator teres, because again, the nerve will run between the two heads of the pronator teres. Now, once we've identified the median nerve, what do we do next? So again, what we're going to do is have that probe in short axis and we're doing an in-plane injection. If you can, I try to sometimes approach from medial to lateral, either at the antecubital fossa or slightly above, sometimes slightly above, just because the brachial artery and the nerve are a little bit separate here to minimize any intravascular injection. What we're going to use is we're using the EMG needle with electrical stimulation. So providing a low intensity stimulation. If I'm right beside the nerve, I should activate the nerve and get activation of the muscle supplied by the nerve. If I do, that confirms my placement. And then you would inject, often sort of a rapid onset anesthetic. And again, to confirm that block, sensory blockade to the median nerve. So here we go with a short axis view. And what I have here, I'm at the level of the elbow, the antecubital fossa. I have the BA or brachial artery on the left, the muscle of the pronator teres on the right, brachialis bottom left, and then the humerus trochlea there. And so the median nerve is basically coursing as we go more distally between the two heads of the pronator teres, and there it is there. So at this level of the antecubital fossa, it's between the pronator teres and the brachialis. Now I'm moving a little bit more proximally. You see sort of the brachial artery and the median nerve are slightly separate. So if you can identify the median nerve, this might be a very reasonable spot to do an injection as you're slightly away from the brachial artery. But it'll depend on the patient that you have in front of you. So again, there's that median nerve. And we're going to go over later how the median nerve is different than the ulnar nerve, which you can't see on this image. And so if we were going to do this procedure, as I alluded to, if we sort of think of this red needle track, I'd be bringing needle from in plane, from medial to lateral, right around the nerve, providing a low current or a low intensity stimulation with the needle. If I'm getting that activation of the median nerve, then I would inject around the nerve. So again, here's that median nerve, and now we're going to follow it back distally. So we're coming Back distally, we're at the level of the antecubital fossa, and now we're slightly more distal. And so what's happening is that the median nerve is now going to course through the heads of the pronator teres. So again, here we are here with the brachial artery, the median nerve, and the pronator teres. And again, just distal to the antecubital fossa. And so certainly this might be a very reasonable spot to do an injection. Certainly at this level, if we're thinking about the clenched fist, we haven't given off those branches to the finger flexors. And so again, if I was doing this injection, I would bring the needle in line with that red arrow from medial to lateral, bringing that needle right beside the nerve, again, providing a low intensity stimulation. If I'm getting activation of the nerve, I'm seeing movement of those supplied muscles, and then I would inject around the nerve. So again, also a reasonable option to do it at this level. And as you see, now it's diving deep, that median nerve basically going just distal, sort of, it's as the video showed there, it was diving between the two heads of the pronator teres, and now it's a little bit deep. So again, there's the median nerve, and just for the sake of education, we're going to follow it a little bit more distally. So as you see here, it's going to track a little bit more superficially, and there is our median nerve. And certainly if you wanted to follow that median nerve, you could follow it all the way to the level of the carpal tunnel. I have another video series on that. So there again is our median nerve. Now what I want to show you is I want to show you how this is different than the ulnar nerve. So right now the probe is in short axis, basically with straddling over the cubital tunnel with the bony landmarks of the medial epicondyle and the humerus. And so there's that hypo or anechoic ulnar nerve at this level. Really easy to identify. Now I'm following it more proximally. And so I'm going to pause. There's my ulnar nerve. And so I have sort of below it and to the left, I have the bony contours of the humerus. The ulnar nerve, the muscle that's sort of deep to it, is the triceps muscle. Now, if I move the probe a little bit more anteriorly or volarly, and we just sort of pause there, there's the median nerve. So again, if you're blocking this nerve just above the antecubital fossa, hopefully this video shows you sort of the different localization between the ulnar nerve, which is a little bit more posterior near the triceps, and the median nerve a little bit more anterior. So that ends my video series today. I'm the neuromuscular mechanic, and I hope you found today's video handy. Take care, and thank you.